Hello everyone, I'm Dr. Divya Gupta, original guru for Periodontics, and today we are here to discuss the most important MCQs for your INI-CET exam, which is in less than 35 days, right? So, uh, in the previous YouTube session, I have discussed about the important topics. I told you and they are nearly the same topics which are there in NEET exams and the INI exams. So I'll not go into the detail of what comes from each topic. I have just jotted them down. You can watch my previous YouTube session, or you can note the topics from here. What all topics are coming, what all topics are there in INI-CET, and these are the topics which we have discussed in detail in our recorded sessions. So those recorded sessions you can definitely go and see, and those recorded sessions means if it is only 30 to 35 days for you all to study all the 19 subjects, then approximately you will have 1.5 to 2 days for a single subject, right? To revise a single subject. So what you can do is all these topics you can go and see from the recorded sessions which we have recorded in our eGurukul app, and you can complete your course in your 2 days. So now these are the topics, guys. Just note it down or click a picture of it, take a screenshot of it, and try to cover at least these topics. Definitely, if 14 or 15 questions are coming in your perio in INI-CET, then I can guarantee you approximately 10 to 12 questions will come from these topics, or more than that. Okay. So just stay focused and plan a proper strategy for your preparation of this last 1 month. So from these topics I have selected few questions. Approximately 8 to 9 questions are there, and these questions I will be discussing in detail. These are the questions. Some of these questions are questions which we don't study in our graduation. Nobody teaches us that. So I have selected such topics so that you will have some clarity about the topic. Though in this half an hour to 45 minutes session, it is not possible for us to complete the whole topic, but important points we'll tell you, so that if a question comes from this topic, you will be able to answer that easily. So let us get started with our first question. So in this question, this question has been asked approximately 2 to 3 times in the last 5 years. Either in NEET or in INI-CET, they have asked this question. So this is the same image which they are using, and the question is, the image below describes what? So guys, instrument topic is very important. Nearly 3 questions, 2 to 3 questions are coming from instrument topics. In instruments, you must know the explorers, the probe, the ultrasonic tips, the piezoelectric tips, the scalars, curates. So what you can do is go through all the images that are given in Carranza, because 99% of the times the images will come from Carranza only and nowhere else. Even if a case is given in the instrument, like in this, I'll show you that how, some case they are describing. And in that also means, for instruments, you must know which type of instrument it is. They can pick an instrument from a case also that is given in the Carranza. So just go through this topic, at least the images in this topic, very nicely in the instrument topic. Okay. So the image below describes what? So the options are an ultrasonic scalar tip, an oscillating saw, piezo surgery tip, or a Humvee knife. Okay. So guys, this is a piezoelectric tip, piezo surgical electric tip. So we will be discussing about the piezo surgical electric tip here. In this diagram, this image is from Carranza. This image is from Carranza. Carranza is the Bible, guys. For perio, everything will come from Carranza and nowhere else. So you must know what is there in the Carranza, and obviously it is not possible for you all to study the whole of Carranza. You have to study 19 subjects. So what I do is, for my subject, for all my recorded sessions, what I have done is everything that is given in Carranza and what is important for our MCQs, I've just make notes of it, and then we are proceeding further. So it's better, to take our recorded sessions, and from there you can, you will get 100% of the Carranza in there. So guys, this is the image directly from Carranza. Here, what you have to see means what I meant by saying you have to see the cases that are given in Carranza is, and what in those cases you have to look for is the instrument tip, the type of tip they are using. So here you can see in Carranza, in the chapter of piezoelectric surgery, they have not given instruments separately. Instruments of piezoelectric surgery are not given separately. So in that case, what you can do is you can look the images. You can study the images which are given. So this is the image here. This image I have taken from Carranza only. Here you can see this tip. This has a serrated end, right? So in this, what they are doing is they are doing ridge augmentation. They are doing ridge augmentation plus ridge augmentation or ridge split. They are increasing the width of the mandible to place the implant. So this tip is specifically used to do ostectomy. This is used to do ostectomy. These incisions which you see here in the bone are made with the help of this piezosurgery instrument, piezosurgery insert. So I'll also tell you another way how you will identify the insert, how you will identify the image if a piezoelectric insert is coming. Okay. So here you can see that piezoelectric instruments, what is the use of the piezoelectric inserts? Piezoelectric inserts work on the principle of piezoelectric unit, right? In which there is, we already know in piezoelectric unit, the instrument tip has a linear motion. What is the use? These piezoelectric units are very costly, and what is the use? Why we have to use these piezoelectric units in our why it is good to do surgeries with piezoelectric unit is because here we have maximum visibility. Maximum visibility. Why maximum visibility? Because in this, the amount of injury that is done to the bone is very less. This piezoelectric unit is used only for hard tissues, not for soft tissues. And there is maximum visibility because it has an effect called cavitation effect. From the tip of the insert, there is a jet of water that is coming out, and that jet of water produces two effects, which are acoustic streaming and cavitation. Cavitation is a process in which there is formation and explosion of the bubble. Because of the high rate at which the water is coming, there is formation and explosion of the bubble that is happening, and because of that, the whole of the debris which is there is excluded from the site, from the field of surgery. Okay, the blood, we get a completely bloodless field. So what happens is our visibility of the surgical site increases. So with the help of piezoelectric inserts, we have good visibility. Also, here there are improved healing. If we do a surgery manually with the help of blade, scalpel, with the help of aerator or micromotor, and we compare, and when we compare it with the help with the microsurgery, then there is improved healing with piezosurgical instruments. Also, the advantages of piezosurgery are it has selective cutting. Selective cutting means it does not harms the, cuts only the mineralized tissues, cuts only mineralized tissue. It does not cut the soft tissue. So we can go near to the nerve. The chances of damage to the inferior alveolar nerve, to the superior alveolar nerve, anterior, posterior, superior alveolar nerve is very negligible in the cases of piezosurgical units. Also, it has excellent healing, as I have already told you. So these are the advantages of piezosurgical unit compared to our manual or rotary instruments which we are using. Now, I told you that I'll tell you a way that you can identify the inserts are. So here it's given. These piezosurgical instruments can be classified as, so guys, what I'm telling you here is important for your MCQs. Just note it down. This picture is also, this classification is given in Carranza. This picture I have taken directly from the Carranza. So here they are classified as sharp instruments. Now from the name only you can say that sharp instruments, what is the function of sharp instruments? To cut, right? It is used to cut the bone, to cut the membrane, right? So these inserts are sharp and they are used for osteotomy and osteoplasty. Other are smoothing instruments. Smoothing instruments are used to remove the calculus. They are used to smoothen the surface for osteoplasty procedures. They are used to, collect the bone. So they are smooth instruments and blunt instruments. These blunt instruments, these are steel colored. So I'll just read it down. The sharp instruments, these inserts have sharp ends used for osteotomy and osteoplasty. They are made up of nitride titanium steel and are golden in color. The sharp instruments will be, the sharp piezosurgical instruments will be golden in color. So this is an important point which you must know. They will be golden in color. Now smoothing instruments, they are also made up of nitride titanium and they are diamond coated. They are used to complete the cut near the soft tissue. They are diamond coated instruments. I'll show you the instruments and then you will understand it more in a more proper way. Blunt instruments, these are steel colored inserts and are characterized by rounded ends. Okay, they have a rounded end and they are generally used to refine the cut in contact with the soft tissues. Now, these clinical instruments are classified. Another classification, how you can identify the inserts are, on the insert tip, it is written, the short form is written OT. OT means the insert, the piezosurgical insert is used to perform osteotomy. Then OP means it is used to perform osteoplasty, osteotomy, osteoplasty, OT, OP. EX means it is used for extraction and IM means it is used for implants, right? So here in this, you can see that it is written OT 8R. 8R you don't have to pay much attention, no. Attention should be paid to this OT. OT means osteotomy, right? So let us see one by one. I have taken some pictures from the Carranza so that you will get a more clear understanding. So here you can see this instrument. This instrument, I hope the image is clear. So this instrument, okay, so this instrument you can see that it is smooth instrument and it has surface that is rough. It is diamond coated. It is golden in color. It is diamond coated and it has smooth surface. It is used for smoothing. This is similar to a tapered fissure burr, the diamond coated steel burrs which we are using in our day-to-day practices. It is similar to it, right? But it is golden in color. So it is an osteoplasty, OP insert. This instrument you can see here, this is also a smooth instrument. It is used for bone harvesting and it is osteoplasty instrument. Next, this instrument, this is used during the time of extraction. At the time of extraction, the root of the tooth is cut without damaging the bone. Thus, the tooth becomes loose in the socket and we can easily extract it with the help of extraction forceps. So, this is also a smooth instrument which is used for, which is helpful in preserving the bone, and it cuts only the tooth so that the tooth will become easily loose and we can easily take it out with the help of forceps. Now these are the different inserts which are used to prepare the implant site. Normally the implants which we are doing in our practices daily is done with the help of steel instruments. Burrs are there. pilot drill is there. Different kinds of drills are there, which we use in physio dispenser, right? But here the implant site in the piezoelectric unit, it is prepared by a different insert, by different drills. So these drills are also golden in color, and here you can see that this is the implant site preparation insert. This is a smooth insert. This is the pilot drill, which is used to drill the hole. Just remember the instrument tip, how it looks. Now here, this image I have kept specifically for, here you can see the diamond. This instrument is diamond coated, so it is used for osteotomy. It is used to cut the bone. Plus this water jet, you can see here this water jet that is coming. This is coming from the instrument tip. It is coming from all the tips, guys. And this jet of spray is coming at a rate of 30 kilohertz frequency. This is the jet which is responsible. You can see here the how clean the field is, how clean it is, bloodless, completely bloodless. This is because of this effect that is produced because of the jet of the water spray. There is cavitation, there is acoustic streaming that produces a bloodless field during surgery. Now, here these are the different kinds of implant drills that are used. This is the blunt instrument. We studied about 3 classifications: sharp, smooth, and blunt. So this is the blunt instrument. They have rounded ends and they are used to harvest the bone. They are used to harvest the bone from, here you can see that they are harvesting the bone from the area surrounding the implant site. Okay. So this was the implant kit that is used. Now next is the maxillary sinus. For maxillary sinus elevation also, all the surgeries which are performed with our physio dispensers and everything, they can be performed with the help of piezoelectric units. Now here you can see that this is a blunt instrument. Sorry, this is a sharp instrument, the tip of the instrument, and this sharp instrument is used to make the incision here. This incision is made with the help of this sharp instrument. A lateral window is created. And now the white thing which you see here, this is the membrane, sinus membrane. This sinus membrane, we need to lift it from the bone. We need to separate it from the bone. So this is done with the help of this. See the tip of this instrument. The tip of this instrument is rounded. This is also a blunt instrument like this, right? So this tip here, I hope it is clear. See this tip. This is used to separate the membrane from the bone. Okay. So these are the different instrument inserts. These are the different piezoelectric inserts which are used, as they have already asked about this serrated instrument, serrated insert before. They can ask any of the inserts. I have already told you how to identify it, and so I have brought a question for you all, and I want you all to answer this question into the comment section below. You tell me which type of insert, piezoelectric insert is this, which type of piezoelectric insert is this, and which piezo kit is this. This kit is what? So I have numbered it 1, 2 and 3. You have to answer that 1 is this piezoelectric insert, means whether it is an osteotomy insert, whether it is an osteoplasty insert, whether it is an implant insert, whether it is a maxillary sinus lift insert. Okay, that you have to tell me. Write the answers in the comment section, and then I'll tell you the answers. Thank you. Now, I hope just, take a screenshot and write the answers. Take your time. I'll answer it in like 2 to 3 days, after 2 to 3 days only. So take your time, go through the explanation which I have told you, and answer the question. Okay, now guys, let us move to the next question. The next question is about the full mouth disinfection. Full mouth disinfection is done within. A very common question, but most of the times we just miss out what is full mouth disinfection, why we need it. So full mouth disinfection is done within 24 hours, 72 hours, 48 hours, or none of the above. So this full mouth disinfection was introduced by Leuven group in the year 1990. This is also an important question. This is asked in MCQs. Now, what is the purpose? Why we need to do a full mouth disinfection in a specific period of time? So, the objective of this full mouth disinfection is to eradicate. It is to eradicate or suppress the periodontal pathogens. Periodontal pathogens in a short period of time. In a short period of time, and that suppression of bacteria or periodontal pathogens is not only from the periodontal pockets, time not only from perio pockets, but also they suppress the pathogens from the other parts of the oral cavity also, like the tongue, tonsils, mucosa, that is the buccal mucosa, alveolar mucosa. All of these oral surfaces are completely disinfected, means the pathogens which are present in the oral cavity are suppressed, and many of them are killed in the process of full mouth disinfection. So this full mouth disinfection is done in 24 hours. It is done in 24 hours. And what all things it covers? What all things are covered in this full mouth disinfection are? It covers full mouth scaling and root planning. Root planning within 24 hours. So we have to do, like, if suppose a patient is not able to do full mouth scaling and root planning in a single sitting, it's difficult, right? You will think that. But in this full mouth disinfection, what we are doing is we are first doing in the morning session for 1 hour, 1.5 hours, we'll do the scaling and root planning, and the remaining of quadrant wise. First, we'll complete this quadrant, then we'll complete this quadrant, and the remaining quadrants are completed after a gap of 3 to 4 hours, or in the evening session. We can easily do it. So this, but we have to complete this scaling and root planning in 24 hours. Then there is subgingival irrigation. Subgingival irrigation of all pockets with 1% chlorhexidine. This is important. This is asked in MCQs. So this 1% chlorhexidine is used to do the subgingival irrigation. Next is tongue brushing. Tongue brushing with antiseptic solution. Septic gel or solution you can use to suppress the bacterial niche. See, there is a coating present onto the tongue. So to suppress that, we can use tongue brushing with the help of antiseptic gel or solution. And lastly, there is mouth rinsing. Mouth rinsing with antiseptic solution. Antiseptic solution to reduce the bacterial load. To reduce bacterial load in saliva and tonsils. Saliva and tonsils. So here you can see that with the help of tongue brushing, we have covered the tongue. Okay. Then with the help of mouth rinsing, we have covered the tonsils. With the help of subgingival irrigation, we have covered the pockets. Scaling and root planing, we have covered the teeth. Mouth rinsing, so we are covering the mucosa as well. So you must know that in 24 hours, quadrant wise we are doing everything. So if a patient is coming in the morning session, what we'll do is select a one quadrant. We'll complete the scaling and root planning. We'll come to the second quadrant. We'll complete the scaling and root planning. We'll come to the first quadrant. There we'll do the subgingival irrigation with the help of 1% chlorhexidine. This is important. Then in after 3 to 4 hours or in the evening session, you can again recall the patient, complete the remaining quadrants with scaling and root planning, do subgingival irrigation. After completing all this, what we do is we do tongue cleaning and mouth rinsing with the antiseptic solution. So this is what full mouth disinfection is. Full mouth disinfection, and this was proposed by Leuven group. This full mouth disinfection is thus the answer to this question is full mouth disinfection is done within 24 hours. Within 24 hours. Okay. Now the next question is ANAC. Every year one question is coming from this topic. So कुछ और पढ़ो ना पढ़ो, instruments, ANAC, these are the two topics which you must know, because at least 4 questions, 2 to 3 questions from instruments and 1 question definitely will come from ANAC. It is the favorite topic for examiners, ANAC. And this we have discussed many times and in great detail in our recorded session. So what is true for ANAC? For this, you must know about the clinical features of ANAC, about the epidemiology of ANAC. You must know the differential diagnosis of ANAC with acute herpetic gingival stomatitis, of ANAC with diphtheria, syphilis. Okay, you must know all that. So what is true for ANAC? The options are: it is seen in children, the duration is variable, it is contagious, or immunity gets developed. So to answer this question, you must know what are the clinical features of ANAC, right? So the first, let us first see what are the clinical features. The clinical features of ANAC. ANAC में से A is right now a misnomer. In ANAC, ANAC means acute necrotizing ulcerative gingivitis, right? So acute is a misnomer. Why? Because there is no chronic form of ANAC. It is only acute. So nowadays we have stopped using the letter or the word acute. It is just the NUG, necrotizing ulcerative gingivitis. So the clinical features of NUG are: it rarely affects the children. It rarely affects children. This is different from acute herpetic gingival stomatitis. Acute herpetic gingival stomatitis is more common in children, right? It is more common. It's primary infection. It is more common in children. Second clinical feature, it is non-contagious. Another differentiating feature from acute herpetic gingival stomatitis. Okay? I'm not going to discuss acute herpetic gingival stomatitis. I'm just telling you the differential diagnosis. Now, this disease occurs in episodic forms. It occurs in episodic forms in patients with immune suppression, in patients with compromised immunity, in patients with compromised immunity. Mostly it is seen in patients who are living in poor, poor socioeconomic groups, in patients living in environment. There is seasonal variation. It is more common in summers than in winters. So in patients living in humid environment, in hot and humid environment, it is more common in patients who are malnourished, in patients in whom the immunity is not developed. So this kind, and it has an episodic nature, means it is occur in a specific period of time. So this is episodic in nature. And how this looks, the oral signs, what are the oral signs of the oral signs are this also many a times we have discussed. The oral signs are: it has a punched out crater like appearance. There is formation of pseudomembrane, and this pseudomembrane can be easily removed. This pseudomembrane is grayish white in color and it can be easily removed. There is fetid odor, metallic taste, pasty saliva, metallic taste, thick pasty saliva, there is excessive salivation, there is because of the necrosis, there is no pocket formation. Another important point, no pocket formation, no pocket formation. There is only recession. There is recession seen, and it affects adults mostly. It is common both in females as well as in um, males. Also, another feature is it is not contagious. It is not contagious. It is not transmitted from one individual to another, and it does not demonstrate any kind of immunity. Any kind of immunity means if an individual has been affected with NUG previously, it's not like any immune cells will develop against it and the patient will not have the disease further. No, it is not like that. The patient can be again affected with NUG, so it does not confers any immunity. Does not confers any immunity. Okay, so these are the features. These features I've just briefly discussed. This we have discussed in detail many a times. So let us again go to the options. What is true for annex? Seen in children, we have seen that it is more common in adults. Duration is variable. It is contagious, and we have seen that it is not contagious and immunity gets developed. We have seen that immunity does not get developed. So the answer to this question is duration is variable. Now the next question is, what is the use of these instruments? Okay, what are these instruments? Such kind of questions come in once, means this is out of the syllabus question, I'll tell you, but as they have asked, it is my duty to tell you that such questions can be asked, and that's why we are discussing this. And I can guarantee you these questions are hard, and if you will not know this question or answer to this question, there is no big deal. It's okay. 95% of the students will not be knowing the answer to this question. So it is completely fine, guys. Okay. But let us discuss this question now. What is the use of these instruments? These instruments are used to check the pocket depth. They are used for measurement of temperature. Gingival, option C is it is used to check gingival inflammation, and number D is gingival biotype. So I'll tell you, these are the color view instruments. So here you have to look why they are called as color view instruments. Color view instruments. They are color coded. They are color coded as black, they are color coded as green and blue. So they are color coded instruments, and these instruments, they are used to check the gingival biotype. They are used to check the gingival biotype. What is gingival biotype? It is the thickness of the gingiva that is covering the tooth and the root. It is used to check gingival biotype. Okay. Now, how we check gingival biotype? So, actually, this sequence in which the image is given is not correct. These instruments should be, we have to invert the image. This is the instrument number 1. This is the instrument number 2. This is the instrument number 3. So, this is the correct image. This is instrument here. The instrument numbering is given. These are the U-Freddy instruments. These are the U-Freddy probes. They are the disposable tips, but these tips can be autoclaved as well. They can be used in approximately 40 to 50 patients. Here you can see that the instruments are numbered. The tips are numbered as 1, 2 and 3. So 1, 2 and 3 does not mean the thickness. It means, I'll tell you how these instruments are used. Now what we do is, we first will take the number 1 instrument. We'll take this instrument first. We will insert it inside the periodontal pocket and we will check it. We'll throw the light onto the this probe, and if this black color is visible, if this black color is visible, is visible means the gingival biotype is thin, means the thickness of the gingiva is thin. So what we have to do? We have to insert the probe into the sulcus. We have to insert the probe, and whether the black band that is there, sorry, not black, the white. Here the white band we'll be seeing the white color, right? So if the white color is visible from the gingiva, then it is a thin biotype. Next is the white color of the instrument. Next is the instrument number 2. If the white color is not visible, means it is not thin, it is more thicker than the number 1 instrument. So we have to insert the second probe, which is the green colored tip. Now this green colored tip we'll insert and we'll throw the light onto the gingiva, and if this green color is visible, then it is green band visible, means the gingiva is medium thick. Okay. If this green band is also not visible, then what we'll do? We'll insert the third probe, and this has the blue tip, right? Again, we'll insert the probe, we'll check it with the light, and if this light, and if the blue band is visible, then it is a thick probe. Blue band visible means thick probe, thick gingival biotype. If this blue band is also not visible, then it is a very thick gingival biotype. And what is why we need to know the thickness of gingival biotype? Because whenever we are, planning for any periodontal surgeries, or we are planning for a bone grafting, we must know if the gingiva is thin and if we are elevating the flap, then there are chances that there will be recession. In cases of extraction, in cases where there is we need to go for implants after extraction, and if we think that there is thin biotype, in those cases we can plan that we can do bone grafting, and then bone grafting membrane can be placed, PRF membrane can be placed, we can close the site so that there will be increased thickness of the gingiva, there will be increase in the thickness of the bone, and we are thus preventing the chances of recession. So this is why we must know what is the gingival biotype. Why gingival biotype is important? To plan our treatment properly, because if the gingival biotype is thin, then there are chances that there will be recession. And in cases where we need to take a split thickness graft, where we need to do recession coverage, we need to take a split thickness graft in recession coverage. So in that cases also, we can easily identify if donor site is thin, it has a thin gingival biotype, we cannot take the graft, otherwise there will be recession, right? If we are taking a connective tissue, a split thickness graft from the donor site, and if it which has a thin gingival biotype, then there will be recession. So we have to avoid taking a graft in cases of thin gingival biotype. So that is why we need to use these instruments. So thus, we can say that what is the use of these instruments? The use of these instruments is to check the gingival biotype. The use of this instrument is to check the gingival biotype. Now let us see the next question. The next question is, after removal of periodontal pack nowadays, it is not used, but yes, many dentists are still using it. Many have stopped using it because of certain reasons. So after removal of periodontal pack after a week of surgery, you see a large rounded elevated granulation tissue. It is most likely due to options are allergy to components in the pack, normal finding, incomplete calculus removal, or mechanical irritation due to periodontal pack. So guys, periodontal pack. What is the periodontal pack? After we have completed our periodontal surgeries, or we have completed our gingivectomy, our crown lengthening, we are covering that surgical site with the periodontal pack. So why we need to cover it with the periodontal pack? We need to cover it with the periodontal pack to protect that site. Periodontal pack does not helps in healing. It does not has any healing properties. It does not has any antibiotic properties. No, guys. It is just for the protection. The patient will also feel safe that something is there and I'm not harming my surgical site. The patient will be more comfortable, and also the patient will be able to chew properly. Nothing will stick to that surgical site. So to just protect that surgical site, we are using periodontal pack. So these periodontal packs, let us discuss. They are of two types. They are zinc oxide eugenol packs and they are non-eugenol packs. Mostly we should use non-eugenol packs because few patients have shown allergy to eugenol, and also there is a specific taste of eugenol is there, which most of the patients don't like. So most commonly preferred periodontal pack is the non-eugenol pack. In eugenol packs, the content of the eugenol packs are zinc acetate eugenol. Example is Wonder Pack by Ward. The non-eugenol packs contains metallic oxides, fatty acids, chlorothiridol, chlorothymol, and the examples are Copac. The periodontal pack which we are using most commonly is the Copac, but now I don't know why, but in India, Copac is not available. They have stopped importing it. So what we do is there is a base in this Copac. There is a base paste and a catalyst paste. We take the tube, both the tubes here. So this is the catalyst, this is the base. We mix it. Catalyst, this is the base. We mix it and then we place it into the water, a normal temperature water at room temperature. Why we are placing it into water? Because it accelerates its setting time. So when it gets set, we can easily take it and we cannot touch it. Setting means it will become semi-solid. It is molded. It is in moldable or clay-like consistency. Then we can easily take it. When we have to take it, we should take it with the wet fingers. We cannot take it with the dry fingers because it will stick to our gloves. We take it and just place it at the surgical site and we'll press it. We'll press it. We'll take the periodontal probe, dip it in water, and then we can press it in the interproximal areas of the tooth. Ask the patient not to eat anything for 1 hour at least, not to spit anything, not to drink water, not to eat anything. In 1 hour, the Copac will harden and the Copac should stay there at the surgical site at least for 1 week. So after 1 week, when we remove the Copacs, this was in brief, in short about the Copac findings. Findings after removal of the pack are, because of the pack, there are chances that there will be more bleeding. Mostly this more bleeding will be seen in cases of gingivectomy. But this is normal. You don't need to worry about it. The surface is covered with friable meshwork of surface epithelium. So there will be formation of a weak epithelium. There will be red protuberances. You can see bleeding points can be seen after you remove the pocket. There will be a whitish membrane. That membrane is your epithelium that is forming. There can be red bead-like protuberances, and these bead-like protuberances, when they are present, they suggest that there can be presence of calculus. So if these bead-like protuberances are present at the area of marginal gingiva, okay, or in the interdental gingiva, if you see a isolated red bead-like protuberance, then mostly it is because of the presence of calculus. This is not a normal finding. Okay, so now these are the findings after removal of the pack. So now let us again go to the question. After removal of the periodontal pack, 1 week after surgery, you see a large rounded elevated granulation tissue. It is most likely due to incomplete calculus removal. This is the answer to this question. Now the next question is cutback incision. I kept this question on purpose because a few days back only someone asked me this question, what is a cutback incision? And I realized that this we have not discussed in a recorded session. So we must know what is a cutback incision, because this is a very common incision. So cutback incision made on a laterally displaced flap. So laterally displaced flap is used in periodontal surgeries. Mostly it is used in a mucogingival surgery and mucogingival surgery. This lateral displaced flap is used commonly for recession coverage, right? So they are asking that cutback incision is made on laterally displaced flap is, what is this cutback incision and how we are doing it? Mesial cut towards the donor side, distal cut towards the donor side, mesial cut towards the recipient side, or distal cut towards the recipient side. Now so let us see the cutback incision. Cutback incision. This cutback incision was given by Korn in the year 1964. So this is the tooth where recession is present. This is the tooth. Okay, guys. This is the mucogingival junction. Now, this is the recipient side, and here it is the donor side. What we do is, donor side means we are taking the laterally positioned flap. For laterally positioned flap, we have already discussed what is laterally positioned flap. We'll take a partial thickness flap from here. Okay, we'll put a vertical incision. First, a horizontal clavicular incision is made, or you can say a horizontal incision like this is made. Then from the line angle of the adjacent tooth, we'll take a vertical incision. This vertical incision is made. This vertical incision is broader at the base, guys. This is, here also incisions are made. Here also we make the incision, and like this, we'll cut here till here. Okay, and this incision is made here. So this base is broad in the vertical incision. Why? This is another MCQ. Why the base is broad in the vertical incision? So that there will be more blood supply for the tissue, right? Here, blood supply is coming from here, right? So there will be more blood supply. Another thing is, we give a cut back incision. This is your cut back incision, guys. This cut back incision is given into the alveolar mucosa, from the mucogingival junction to the alveolar mucosa, and you can see that this is given on the distal side of the flap. We are not giving it here. We are so we are not giving this incision here. No, we are giving it here, and this incision is like this. The line is like this. It is at an acute angle to the horizontal incision, and it is towards the recipient side. Here you can see that this is towards the recipient side. It is not away from the recipient side. It is towards the recipient side and on the distal aspect of the donor flap, right? So what this incision does is, this attached gingiva, as you all know, it is immovable. So if we just give the vertical incision, the mobility of the flap will not be that much, and there will be tension here. If we are not giving this cutback incision, then there will be tension or muscle pull on this side. So what will happen? It will, whenever a patient is talking, eating during the period of healing, if we have placed, without giving a cutback incision, we have placed the flap here at this side. We have covered it, right? We have covered this region with this flap, but we are not given the cutback incision. So what will happen? There will be a pull at this region. There will be a muscle pull here. Because of that muscle pull, the flap will try to come downwards. So that will impede the healing of the flap. So by giving the cutback incision, first thing what we are doing is we are releasing the muscle pull. By giving a cutback incision, we are decreasing muscle pull or tension. Second thing what we are doing is we are increasing the mobility of the flap. Increasing mobility of flap towards the donor side. When we are doing this, giving this cutback incision, now the flap will be more mobile. Why? Because the alveolar mucosa is more mobile. We have undermined the underlining muscles, the underlining fibers. So now the flap becomes more mobile. We can easily able to pull it, and also there will be less tension. So these are the uses of cutback incision. Now, I hope you will be able to answer this question. Cutback incision made on laterally displaced flap is a mesial cut towards donor side, distal cut towards donor sides, mesial cut towards recipient side, or distal cut towards recipient side. So, the answer to this question is it is a distal cut that is going towards the recipient side. Okay. Now, this question is like a very common question, means not something out of the blue, but a simple but a confusing question. Why it is confusing? I'll tell you. Plaque hypothesis. Plaque hypothesis in deciduous tooth enumerate the correct sequence of events. So they are asking you in this question, they are asking you about the stages of plaque formation. Stages of plaque formation, but the thing they have mentioned here is the deciduous tooth. Deciduous tooth. Some of you might be thinking, अरे यार deciduous tooth पूछा है तो कुछ तो अलग होगा है. इतना easy question तो they will not ask. 50 to 60% of the students, I also used to think the same in the same direction कि यार इतना easy question तो नहीं होगा, कुछ तो इस question में twist होगा, as they have asked in deciduous tooth, right? So 50 to 60% of the students will think like that. So I have kept this question. So they have asked plaque hypothesis in deciduous tooth, enumerate the correct sequence of events. They have given attachment of bacteria to pellicle, acquired pellicle formation, aggregation of species, detachment and adhesion of organism to the tooth surface. We all know dental plaque तो सबने एकदम अच्छे से पढ़ा है final year में, and our students also have studied it very nicely. So we all know the stages of plaque formation. What is there? First, there will be formation of pellicle. So they have asked what will be the sequence, whether it will be one that will be happening first, or the event 2 will be happening first. So they have asked you the sequence of events that will be happening during the formation of plaque in the deciduous tooth, in the primary tooth in children. So as we all know, first there will be formation of acquired pellicle. So guys, the events will be similar. Events will be similar to the permanent teeth. There is nothing different. The events will be same. First, there will be formation of pellicle. Then the bacteria will come. The bacteria will attach. There will be attachment of bacteria to the pellicle. Then there will be adhesion of organism of the tooth surface. So here first there will be formation of acquired pellicle formation. So there will be number 2 will come first. Second, there will be adhesion of organism to the tooth surface because of the Brownian movement, ionic bonding, covalent bonding. Then attachment of bacteria to the pellicle. There will be firm. Initial adhesion is weak. Then there will be final attachment or more firm attachment of bacteria to the tooth surface. Then there will be aggregation, co-aggregation. Primary and secondary colonizers will come and they will aggregate among themselves. There will be concave formation, tube bristle brush formation will be there. And finally, there will be detachment. Okay, so thus, for stages of formation will be same both in deciduous and permanent tooth. Permanent tooth, deciduous is just given to confuse the students. Now the last question is on the host modulation. Host modulation, by which of these is used for periodontal? So this question is bit tricky and confusing. Host modulation, by which of these is used for periodontal conditioning and regenerative procedure? So what is periodontal conditioning? Periodontal conditioning is a process in which the root surface of the tooth is conditioned in such a way that there will be enhancement in the attachment of periodontal ligament. There will be enhancement of attachment of tissues to the tooth surface. There will be more improved regeneration. So what is done in periodontal conditioning is the root surface, the cemental surface of the tooth after scaling and root planing, and when we are elevating the flap, it is treated with certain chemical agents to increase its bond or to attract more of the fibroblasts to the tooth surface. So there will be more formation of collagen fibers, more formation of periodontal ligament. To enhance that surface treatment is done, and that surface treatment is called as periodontal conditioning. The three most commonly used agents for periodontal conditioning are citric acid, tetracycline, and fibronectin. So here they have given, apart from tetracycline, other molecules or other drugs which are there in tetracycline, like the doxycycline, hyclate, minocycline, all these can also be used. But for periodontal conditioning, most commonly the tetracycline is used. So host modulation, by which of these is used for periodontal conditioning and regenerative procedure? The answer to this question is tetracycline. I'll just tell you in detail what is done, what are the properties of tetracycline that helps in regeneration is. So what we do is here tetracycline hydrochloride. Tetracycline hydrochloride is used, and the pH. The pH of this hydrochloride is, the pH is less than 3. Okay, इसका pH is less than 3 means it is acidic. So it is acidic, it is able to demineralize it, demineralize the root surface. So what is done is the tetracycline binds with the calcium. It is seen that the tetracycline binds with the calcium that is present onto the cemental surface, onto the dentinal tubules, and it will chelate the calcium. It will bind with the calcium and it will take it away with the, also because it is demineralizing the root surface, what will happen? There will be exposure of the dentinal tubules. That's, there will be more proper binding of the fibroblast to the root surface, and there will be more deposition. Also, it is seen that it has a longer lasting effect. It lasts up till 48 hours to 14 days. So it has a longer lasting effect. So what we do is we'll take a cotton swab, we'll dip it in tetracycline hydrochloride solution, and we'll rub the root surface with the tetracycline for 5 minutes. Thus what happens is, because tetracycline has certain properties, it will enhance the, it increases fibronectin binding. Fibronectin is present into the tissues. It increases the binding of fibronectin to the root surface, and this fibronectin is responsible for stimulating the fibroblast. It will attract more of the fibroblast from the surrounding connective tissue, and more fibroblasts will come and attach to the root surface, and there will be more formation of collagen, more formation of periodontal ligament, right? It causes smear layer removal. The smear layer, the meshwork that is present between the dentinal tubules in the cemental surface, it helps in removing, the tetracycline removes that smear layer, that thus it exposes the dentinal tubules, and more binding of collagen fibers can occur. It provides increased surface, more surface will be available for the collagen fibers to bind. Next is, it stimulates endothelial growth factor binding to the dentin. Thus, these are the growth factors which help in collagen formation. It absorbs to the enamel and dentin and acts as an antimicrobial. We know that it has an anticollagenollytic activity. It has an antimicrobial property. Thus, whatever remaining or residual infection is there, it can easily tackle it within a period of 48 to 14 days, right? Also, it has anticollagenollytic effect that we have seen. So, because of this properties, tetracycline is one of the most recommended periodontal conditioning agent. This conditioning helps in improving the attachment of periodontal ligament fibers to the tooth surface. And in periodontal regeneration, what we are doing, we have studied periodontal regeneration. We are using a bone graft, we are using a membrane. So when we'll treat the root surface with the help of tetracycline. Apart from tetracycline, other agents which can be used are citric acid and fibronectin. We can use any one amongst any of these three. We'll rub the tooth surface and we'll place the membrane. Now what will happen? Within the membrane, the fibroblast will come and they'll help in the formation of periodontal ligament. And on the other side of the membrane, there will be formation of the bone, right? So this is how it enhances the ability of periodontal regeneration. Now I hope the question is clear. Host modulation. Why they are asking about host modulation? Host modulation is we are modulating the host. We are modulating the host in a way like we are modulating the fibroblast to produce more of the collagen fibers. We are modulating the osteoblast. So it is said host modulation. By which of these is used for periodontal conditioning and regenerative procedure? The answer to this question is tetracycline. So guys, with this, we have completed our session. I will request you, if you have any doubts, you can ask me in the comment section. I will be more than happy to answer. And guys, just keep studying hard. Only 30 to 35 days are remaining for your INI-CET. I hope all of you are well prepared and all the best for your INI-CET exams. Thank you so much.